Hi everybody, we're going to do PPE training here. We're going to go over in depth what the command staff has put out over the last 2 weeks with a couple new changes and some consistent nomenclature. So we're going to start calling our level 2 PPE gloves, goggles, and an N95 mask as our medium precaution. This is what the scout is already wearing. So when our scout goes into a house, this is what they have to have on at a minimum. They get in there, they ask all the questions that they have been asking all this time: fever, cough, respiratory distress, signs and symptoms of a potential COVID patient. Okay? None of that changes. We need to get a temperature on every patient. Go ahead and do it. We have the temporal thermometers. Make sure you're using those, please. When the scout's inside, we should have someone at the front door of the house. It's working out pretty well to leave them outside of the structure and let that scout relay to that door person what they need. If only one more person is needed, help that one person get the cot in the door, or preferably have that patient walk to the front door if possible. Don't make sick people walk to the cot or to the front door, but if they're able and to ambulate, allow them. Send that one person in and let those two people be the only people within 6 feet of that patient. Both of them should then have gloves, goggles, and an N95 mask on and level 2 protection. Don't let your standard of care change. If you need more people, take more people. Just have all of the people that you have in the back of that ambulance or within 6 feet of that patient have their proper PPE on at a level 2 at a minimum. So when we're doing our treatment and our precautions, be safe, be smart. All the runs that we've been on, or at least the ones that I've been on, everyone's been really reasonable. They understand what's happening. No one has gotten mad about the surgical masks. They're there for our protection. Use the surgical mask on the patient. They're good for them. They're good for us. Put them over nasal cannulas. Put them over non-rebreathers. Minimize providers in the building and in the back of the ambulance, please. Just don't expose ourselves unnecessarily. Don't take oral temperatures with the thermometers that have been in the buses for many years now. Use our temporal ones. We don't want to expose ourselves unnecessarily to fluid and droplets. Eyes and mouth are a route of transmission. We want to avoid that. Transport precautions, my apologies. Drivers, don't touch your face to remove your eye protection unless your eye protection is fogging up. Minimize that. Leave it on if it's not fogging up. Take your gloves off only. Be really cognizant of how often you are touching things. Because from the point that you're on that run and you've been within 6 feet of that patient, you need to assume that you need disinfected until you have a chance to disinfect everything. Our high-risk facilities are going to jump up to level 3 automatically. Level 3 is goggles, gloves, mask, gown. Assisted care, adult family home, nursing home, clinics, jails. Don't have a whole lot of those that are listed there, but what we do have are places where we can inadvertently run into people unexpectedly. Those should be your high risks. Okay, we don't want to unnecessarily or unknowingly expose ourselves to someone that we had no intention of running into. So be wary of that, and if you think that jumps up to a level 3, just go ahead and jump up to a level 3 and put that gown on along with your other PPE. High-level precautions, level 3. These are our folks with the fever, the cough, respiratory distress. We know they have COVID. They've had previous contact with a COVID patient. We have a very high suspicion they have COVID. This patient was maybe in one of those high-risk facilities being cared for. They were in isolation, and they told you all this. These folks automatically ramp us up to that level 3 PPE. If they are no's to all these questions here, you can read this, then you can obviously follow this algorithm here and use level 2. If we have someone that we suspect of COVID-19, or we know that they do, just don't forget about this part. I know it's already been said a couple times, but we have a lot of moving parts in this. Contact your destination hospital via the cell phone and tell someone that you have a patient who is going to need to isolate it. They need to know that, need to prep that because we don't want to expose their staff unnecessarily. Same as we don't want to be exposed unnecessarily. So give them as much heads up as possible. So while you're in the back of the ambulance, you're treating our folks. We mentioned this a little bit above, but aerosolizing procedures, when we're treating our folks, again, our standard of care doesn't change. We want to maintain our high level of care that we expect at Liberty. We just got to change the way we do things just a little bit. So if we got level 3 PPE required during all aerosolized generating procedures, you know how it says all, not just folks with COVID, all. If we are generating fluids from a patient into the back of a confined ambulance, then we need to be in level 3. So beyond some of our aerosolized and airway procedures, further into BVMs, we're looking at getting HEPA filters. We do not have these yet. You're going to see a picture below about how to use those. Command staff's working on that. Supraglottic airways could be a consideration if we have a suspected or known COVID patient. Obviously, that keeps us out of the patient's airway path. So just use that. We don't have ventilators. Pretty straightforward. Maximize ventilation. We're going to talk about that a little bit more down here. Transporting instructions. We haven't had an issue with this as far as I'm aware, but just realize that we are not taking family members with us except parents and guardians, power of attorneys, and special needs folks. We had a parent the other day. If you explain this to them, I think they're very understanding of what's going on. And the kid was a little older anyways, so it was a good learning experience for everybody. And I think that the parents in the end didn't want to be exposed to our ambulance. So I think that is just a little bit of a chance for us to educate our patients a little bit more. So CDC hospitals are not accepting any visitors right now. That's really not our wheelhouse so much, but just realize that they're limiting visitors big time. So refer them to the hospital staff, because I'm sure each hospital is probably a little bit different, especially when it comes to kids. Ambulance drivers, isolate yourself from the patient compartment. We've done that, obviously, with our shields, but be smart about what you're touching. Be cognizant of what you're touching and realize that everything needs to get disinfected. During transport, this is where those exhaust fans come into play. Don't open windows and don't circulate air in a infected medic unit. Every medic unit on every run is assumed infected until we disinfect it, because we got to clean them. So just don't use the windows. Use your exhaust fans if you feel like you need to move some air, but don't exchange air between you and a patient unnecessarily. Here's your decontamination checklist. This is everything that we've been doing after runs, just in a lot more detail, and it gives you a nice order of things. If we have, so that aerosolized generating procedures up above for our COVID, and we have a COVID-19 patient, or we had a run where we warranted a higher level decon for whatever reason, this is the steps that you need to follow. So go ahead and do your patient transfer like you normally would. Dispose of your PPE. Like Chief Klusman said, that's in a biohazard bag. Treat it like your fire gear after a run. Tie that stuff up real tight. Throw it away. Get rid of it. Allow patient compartments to air out just like you normally have been before you're fogging them. Allow that normal, natural air exchange. Deep clean the medic units. We're doing that at the at the ERs. Remember, with our foggers. That's why they're on the buses. Don't forget to be deconning your boots. We're not supposed to be wearing station boots in the firehouses anymore anyways, but there's no reason for you to contaminate your gear locker any more than you need to. Keep on deconning those boots. Once you're outside the rig and you've started, done steps 1 through 3, and you're ready to remove your uniforms, get a bag and put them in there and seal those up real good and put them in an outside compartment. Get some clean scrubs just like normal from the hospital. Like if we had a bad trauma run, that hasn't changed. And then return to the station, launder everything while you're wearing some PPE, shower, and then don some fresh uniforms. So cleaning the EMS units hasn't really changed, guys. We're doing that at the ER. Make sure you're wearing your proper PPE when you're doing this stuff, because you're going to be coming into contact with potentially infected surfaces. So high touch areas, don't forget about our cables, our 12 lead cables, our BP cuffs. Frequently used equipment needs to get wiped down with the Cavi wipes, our disinfectant spray. Let that stuff sit. Our fogger disinfectant sits for 10 minutes. Don't forget that. Really disinfect everything. That way we can be assured that the next time we get in there, the next time we put a different patient in there, we're doing the right thing for those people too. Here's our oxygen airway slides and what can go over them. As stated above, these are a go. Go ahead and put those surgical masks over those. These are our BVMs and or a supraglottic device with the HEPA filters and our end-tidal. We still need to be maintaining our end-tidal levels. We need to be doing our good standard of care. This is what it could look like if we end up getting those. This is your isolation stuff here. This is all the stuff we've been asking people anyways. Don't forget to ask this. If we have this, we've got to let the hospitals know that they have a potential to isolate someone. And then also that we need to be extra careful about how we're moving. Move side to side. Don't turn your head a lot. Try not to break the seal on your N95s. Keep away from their face and try to stand behind them when you're talking to them when they're talking. Don't expose your eyes and your mouth to any fluid droplet. That's the route of transmission. Exposures, if they've had any of the following in the last 14 days of symptom onset, then they could potentially be an exposure. We're right in here as a healthcare healthcare worker for high-risk occupation, so just realize that we're right there in the high-risk area. These are our medium probability of isolations: cough, runny nose, sore throat. You can proceed on down, and then we can notify them that they're a low probability because they don't meet anything above. So this is what the hospitals are using for their potential isolations. Obviously, we're included in that. So give those a good read over. We're going to have these available because obviously memorizing all this stuff is just not going to be possible. If we have someone who needs to be isolated, have the driver go in and register the patient and then coordinate with hospital staff on where we're going to go. That way we travel as little possible and expose as little possible the ER to our potential patient that's going to get isolated. So that's a big one there. So here's our response workflow. This is everything that we've just talked about. Okay, every call, gloves, goggles, N95, including our MVCs and any other trauma, gunshot wounds. Just wear it. We've got the PPE. Let's use it. Go through all your signs and symptoms. Are we at a high-risk facility? Are we going to be potentially doing anything aerosolized, generating, or anywhere near the airway? Do we need to do any of this stuff? And then follow along down our flow chart here, just like we just talked about. Use this to your advantage. We have an evolving situation that's changing daily. So don't feel ashamed that you need to look at something to remind yourselves. You should be doing that. That's okay. We have checklists for a reason. Make sure you're protecting yourselves. Donning and doffing sequences, Meg and Jim. Mask, eyes, gown, gloves. That's how you put stuff on. Taking it off is the reverse sequence. Gloves, gown, wash your hands. Eyes, mask, wash your hands. We should be washing our hands a lot throughout every single day. At the hospital, there's that driver registering the coordinated patient again. Here's another decon flow chart. This goes through everything that we've just talked about. Make sure you are doing your due diligence about protecting yourselves and cleaning everything appropriately. We have the disinfectant. There's no reason to run the risk. We don't want to lose a bunch of us to quarantine and potentially expose our families. So do your due diligence. Make sure you're deconning appropriately. Decon at the hospitals. Read over this with your crews. Here's our different levels. Level 1, not happening. At a minimum, everyone within 6 feet should be doing this. If we decide it's a COVID patient, we're doing this. This is what it could look like if you get quarantined. These are the questions you're going to have to answer. And that is it. Make sure you take your test fill out your roster, and do an evaluation. Thanks.